This session is one of the most important parts of the day because it brings together symptom recognition, intake quality, red flag awareness, and patient safety. We are focusing on common GI symptoms and conditions seen in specialty clinic. Your role as an MA is not to diagnose, but it is absolutely to recognize meaningful symptom patterns, document clearly, and know when something should be escalated right away. To keep this organized, let's start with the symptom list you will hear over and over in GI clinic: abdominal pain, reflux or heartburn, nausea and vomiting, trouble swallowing, diarrhea, constipation, bloating, rectal bleeding, black stool, weight loss, jaundice, and change in bowel habits. These complaints may sound common, but the details matter. Bleeding is not enough. Diarrhea is not enough. Abdominal pain is not enough. Good GI intake depends on follow up questions. Take our abdominal pain. As an example, where is the pain? Upper belly, lower belly, right side, left side, middle. When did it start? Is it constant or intermittent? Does it happen after eating? Is there fever, vomiting, diarrhea, or blood with it? Severe abdominal pain, especially with fever, vomiting, or weakness, is more concerning and may require urgent escalation. Now, think about reflux or heartburn. Patients may describe burning in the chest, a sour taste, regurgitation, cough, or hoarseness. Some older adults may not describe classic heartburn at all. They may simply say food comes back up or that certain meals make them miserable. That pattern can fit GERD, which is common in GI clinic. Nausea and vomiting also need detail. How long has it been happening? Is the patient able to keep liquids down? Is there dehydration? Is there vomiting blood? Vomiting blood is a red flag and needs urgent attention. Trouble swallowing, also called dysphagia, is especially important. If a patient says food gets stuck, swallowing hurts, or they are losing weight because eating is hard, that should catch your attention. Trouble swallowing with weight loss is a red flag that should not sit quietly in routine workflow. Let's move to bowel symptoms. Diarrhea is common, but not all diarrhea is the same. Ask how often it happens, how long it has been going on, whether there is blood, whether it wakes the patient from sleep, whether there is fever, and whether the stool is watery. Chronic diarrhea can be related to IBS, medication effects, infection history, microscopic colitis, celiac disease, or inflammatory bowel disease. Your job is not to sort out the diagnosis. Your job is to document useful detail and recognize danger signs. Constipation is also extremely common, especially in older adults. It may relate to medications, hydration, mobility, diet, or underlying GI problems. Ask about stool frequency, how hard the stool is, how long the pattern has been going on, and whether there is pain, vomiting, or bleeding. Constipation sounds routine, but severe pain, vomiting, or inability to pass stool can be more concerning. Now let's talk about rectal bleeding and black stool. Bright red blood may be from hemorrhoids, but that does not mean it should be ignored. Bleeding still needs careful review. Black terry stool is especially important because it may suggest bleeding higher in the GI tract. Heavy rectal bleeding is also a red flag. Never treat bleeding as trivial just because the patient sounds calm. Other important warning signs include weight loss, new jaundice, fainting or weakness, and severe dehydration. These symptoms change the urgency of the situation. Now that we have the symptom patterns in view, let's connect them to some of the most common conditions you will hear about in GI clinic. GERD often causes heartburn, sour taste, regurgitation, and sometimes cough or hoarseness. Dyspepsia, gastritis, and peptic ulcer disease also can cause upper belly pain, nausea, early fullness, and may be linked to NSAID use or H. pylori. IBS and other disorders of gut-brain interaction are commonly shown. Patients may have IBS with constipation, IBS with diarrhea, or mixed symptoms. These are real symptoms, but they do not erase the need to watch for bleeding, weight loss, fever, or other red flags. Diverticulosis can be common and silent. Diverticulitis is different and may cause left lower abdominal pain, fever, and tenderness. Inflammatory bowel disease, including Crohn's disease and ulcerative colitis, may present with diarrhea, abdominal pain, blood and stool, weight loss, and fatigue. Celiac disease eyes can show up as diarrhea, bloating, weight loss, or anemia. Liver disease may involve jaundice, swelling, itching, fatigue, fatty liver, hepatitis, or cirrhosis. Gallbladder and pancreatic disease may cause right upper quadrant pain, pain after fatty foods, or severe upper abdominal pain radiating to the back. As an MA, one of your most valuable skills is separating routine symptom reporting from urgent escalation. So let's repeat the urgent list one more time: vomiting blood, black tarry stool, heavy rectal bleeding, severe abdominal pain, fever with abdominal pain, new jaundice, trouble swallowing with weight loss, severe dehydration, and fainting or weakness. Those symptoms should move quickly to the provider team. When you document, be specific. Instead of writing diarrhea, write frequency, duration, and whether there is blood or mucus. Instead of constipation, note frequency, stool consistency, and whether there is pain or vomiting. Instead of bleeding, note color, amount, and whether the patient feels weak. Here's the big takeaway from this session. In GI clinic, symptom details are not extra, they are essential. Better questions lead to better documentation, safer triage, and better patient care.